All right. I'm Derek Colmenares. I am a family medicine physician and the Chief Medical Officer for Agnesian HealthCare. I'm filling in for Holly Brenner today, and I'm excited to welcome you to what promises to be an informative session this morning. To those of you who are joining us for the first time, thank you. To those of you who are back for more, we welcome you and thank you back. We do sincerely appreciate that you're here for us today. To start, I'd like to start with our reflection. I'm very excited to share our 2015 Pink Glove Dance entry with all of you. This is the 4th year that Agnesian HealthCare, in collaboration with the Fond du Lac Family YMCA, has submitted a Pink Glove Dance. Now, this competition helps to raise awareness and money to benefit cancer research. In that time, we have welcomed nearly 2,000 community members, survivors, and associates who participated in the dances. Now, this year's entry features an uplifting tribute by Ellie Baldus, one of our radiation therapists. Throughout the video, Ellie collects pink balloons from various community members. These balloons celebrate cancer survivors among us, as well as those who have left us. Ellie serves as a beacon of hope to those around her, carrying the lives of our loved ones with her as she moves on. So Colleen will play the video. Trying to spot myself in the color run. I did throw orange this year. Can't find myself though. All right, so what's your next step in helping to conquer cancer? We need your vote. Share and vote some more. You can view and vote once a day for Agnesian's HealthCare Pink Glove Dance video on agnesian.com/Pink Glove Dance. Once you do that once, we can even vote for you. So please do that. You can come back and vote many times. Little housekeeping. We have our associates with us this morning in Ripon and Waupun via video conference, hello. And we are also recording this for vital signs. So on your table in front of you, a few things. Know and Go for next month. Dr. Philip Troike, one of our radiation oncologists, will be giving a discussion on preventing cancer through exercise. Hope to see you there. We have our yellow comment cards. Please keep these coming in. We do value your feedback, and we do make changes based on what you send us. And if you'd like credit for being here this morning and you're interested in winning one of our rolling bags over there today, fill out the green slips here. All right, now for some introductions. It's my pleasure to introduce our program. Our topic this morning is inpatient and outpatient rehabilitation. We will hear from our physical, occupational, and speech therapists, as well as athletic trainers, and we'll leave here today more informed about the comprehensive therapies that are available within Agnesian HealthCare. We have several presenters today, but first I'd like to go ahead and introduce Zach Pitts. Zach is our Director of Musculoskeletal and Rehab Services. Zach.
Catch stuff. I'm going to get an extra one so I can win. Thanks everyone for coming. As Dr. Coleman said, I'm a physical therapist by trade. I'm also an athlete trainer, practiced for about 10 years. Went to lacrosse for my master's and got my doctorate through Temple. Super excited with all the things that we're able to bring to you today. Looking at it, it's almost, how do I say it? It's pretty crazy all the things that we do and treat and the number of things that we see. So I hope you get appreciation for that as we go through today. Who's on therapy services? You can see here athlete trainers, occupational therapists, occupational therapy assistants. We have speech language pathologists. We have the physical therapy assistants, and then we also have a ton of support personnel. Also, in some areas, we have cardiac rehab that's in our area, but just for this, we're not going to talk a lot about it. Our locations, so Sports and Spine is our outpatient clinic name, and we have 6 locations. I think most of you are aware of them probably. You may not be aware that we have a therapist at the YMCA, and we have the clinic at Mayville, and then we have the Camelot Drive and 3 hospitals. I didn't list on here, but then obviously we have the inpatient rehabilitation at all 3 hospitals as well. There's various staff that go between those, inpatient and outpatient, depending on their interest and skill mix, so we go back and forth in that. We have about 70 licensed therapists in our organization, in our department. That doesn't include home care or at St. Francis Home. So we have roughly 45 to 50 physical therapists, about 15 plus occupational therapists, 4 or 5 speech therapists, and then around 10 athlete trainers. So a lot of, I think people, when I say there's 22 physical therapists on Camelot Drive, they say, really? So there's a lot of therapists, a lot of specialization that occurs. So we're going to try to present some of that specialization today. The trick with having a lot of people talk is not really trying to give you enough information without getting too deep, without glossing over it. So we're trying to do that balance of getting you the information. At the end, like we said, we'll have questions if there's something specific about a specialty program or something you want to know more about, or we love to talk about it. So that's there. I'll take my sheet out of the way so you don't have to. The green sheet's just going to stand around.
Don't want that to win.
One more time, because it falls down.
So I'm Carrie from Speech Therapy. Agnesian has a department of 4 speech therapists right now. I'm located primarily here at St. Agnes Hospital, servicing kind of our inpatients. But I get to speak today, so forgive me. So what is speech therapy? Since you work in a hospital, you probably have some concept of what speech therapy does in the hospital or kind of our medical involvement, but most of the community would think it's just, the school therapist. Articulation disorders are similar to that with the kids. But here in the hospital, we do incorporate some of that as well within our outpatient department. In general, speech therapy does treat speech and language disorders, again, the articulation, the language difficulties, communication and cognition disorders, which we might see with the altered medical status patients, the confusion, the dementia, memory difficulties, kind of more that cognitive sort of processing difficulty. Voice disorders, we'll see patients with the vocal abuse, vocal nodules, damage to the throat affecting that voice. And then some swallowing disorders as well, chewing disorders, drooling, lip escapage disorders, aspiration, penetration, clearing into pneumonia type of patients. And then speech therapy, who we see people for really across all the ages in Agnesian HealthCare. We've got therapists dedicated really to working with the 0 to 3 populations, the childhood populations, and then several therapists really working through across all the ages, and then I'm more the adult and geriatric specialist therapist. Not using the clicker. Okay, where do we see patients in speech therapy here at Agnesian HealthCare? Our Department of 4 does see patients at all the main clinics. We will travel to upon. We do cover Ripon Medical Center as well, and then certainly here at St. Agnes. We also do send people, we've got a therapist that sees people in their home through home care services, and our pediatric therapist does do birth to 3, seeing children in their home, so kind of more naturalistic, functional, real life therapy in those 2 situations. Okay, so here with Agnesian in the outpatient pediatric department, she does specialize in kind of some infant feeding things, works on autism, developmental issues with the kids. Our outpatient adult speech therapist really is working with the stroke patients, mainly the ones we'll see at the hospital that aren't rehabilitated quickly. She does follow them then through, once they're discharged, and follows them really till they get more functional skills and working with the families and the patients to educate with different options, communication options available. So able to do a little bit longer term therapy than what we have on the inpatient side. Also sees a lot of traumatic brain injury. And then the swallowing, the dysphagia as well, the swallowing disorders. New trends in outpatient therapy would be the use of the kind of our iPad technology. There's a lot of great communication and speaking apps that are just kind of coming into the market the last year or two to help people that can't talk anymore, as well as some home practice programs that were able to help transition some of the therapy techniques for better improvement. And then a lot of brain games, and you might see those on commercials as well, for memory, logics, reasoning, those sorts of things to help keep the brain stimulated and learning. Okay. Inpatient services, mainly the patients we'll be seeing, our big diagnoses are the stroke patients, Parkinson's disease, and then swallowing difficulties, the dysphagia patients as well. New trend in the pneumonia care is the speech role in pneumonia care. The doctors are looking at kind of identifying any contributing factors to pneumonia patients, and certainly difficulty swallowing can be a big part of that. Looking to decrease the future admissions of pneumonia if we can get that treated. So we're starting to see quicker swallow evaluations, quicker referrals to speech therapy to help treat that pneumonia. And then one of our specialty evaluations is video fluoroscopy. It's done in conjunction with medical imaging. Done an x-ray, the patient actually gets to swallow the barium, and we have them do some liquids, some purees, some hard solids, and actually able to watch then what is happening in the throat.
The red button network.
Doesn't seem to be doing anything. But, okay. The first one is a normal swallow. You can see that the dark liquid is kind of nice and contained, going very in a nice smooth column. The one on the far side is an abnormal swallow. So a patient who is having some difficulty, the coughing, the choking, but it's not going down. On x-ray, we're able to see that and then diagnose what part of the throat is not working, and then assign some treatment options for them. Exercises, thickened liquids, that sort of thing. Again, helping them maintain their eating ability, even if it's in some altered form, purees or chopped up, but still giving them a little bit of quality of life and assigning exercises then to treat that. Okay, and then as part of the rehab team, certainly speech therapy, we work to restore the two human functions that we usually take for granted, eating and talking. So my challenge for you today is to appreciate the ease of your everyday talking with your colleagues today, and when you're drinking your water, eating your lunch, think, oh yeah, think of all the muscle function and brain function that goes into doing that, and imagine what it would be like if you couldn't.
Okay, my name is Wendy Krieger, and I'm an occupational therapist. I've been at Agnesian for probably about 8 years now. Prior to that, I was at Watertown Hospital, working in all areas of inpatient therapy, outpatient therapy, and I'm a certified lymphedema therapist, so that's primarily what I do now at Agnesian here in the hospital. But occupational therapists in general treat injured, ill, disabled patients through the therapeutic use of everyday activities. We help patients develop, recover, and improve the skills needed for daily living and working. Our goal of an OT is to assist patients in regaining their independence through purposeful activities. I'm going to start with inpatient therapy. Sometimes we go in to see a patient and he's 88 years old, and he says, I don't need any occupational therapy. I've been retired for 20 years. And so we educate the occupation now, it's anything you do from basically the time you wake up in the morning until the time you go to bed. Occupation is brushing your teeth, is making your bed, is getting the mail, things like that. So inpatient-wise, we work, again, we assist patients on regaining their level of independence. So we do that. We assess performance, safety, balance, cognition, motor planning, problem solving through activities for daily living. That's kind of our buzzword here. Activities for daily living encompasses everything we do. So we assess patients within bathing and dressing. Are they able to get out of bed, walk to the bathroom? Can they balance at the sink while they brush their teeth? Things like that. We do kitchen assessments, home safety tasks, home management. We might have someone fold towels in therapy. Can they stand? Can they use both hands? Or if one hand is injured, can they do that activity with one hand? Can we teach them a new way to do that activity? Community integration, money management. We instruct on adaptive equipment. If someone has tremors and has difficulty holding anything in their hand, we might recommend weighted utensils so that they are able to feed themselves independently. We teach them energy conservation tasks, and we also do upper body exercises so that they improve their strength and endurance so that they are able to perform those activities for daily living in hopes of getting them back home. Outpatient occupational therapy, pretty much we work on anything from the hand to the shoulder. That's kind of a general OT. We have a certified hand therapist at the Camelot location, focuses on mainly the hand, but when we say the hand, it pretty much can go up to the shoulder. Common diagnosis is, everything pretty much under the sun from CVAs, traumatic brain injury, neurological disorders, tendonitis, arthritis, fractures, surgeries, work-related injuries, neuropathies, carpal tunnel syndrome, thoracic outlet, work with ergonomics, making their job site and their body to fit that together. We do splinting and then lymphedema therapy, which I'll talk about next. Lymphedema therapy, work on the lymphatic system. Very important in the body. The lymphatic system returns protein to the cardiovascular system, removes excess fluid from the interstitium, helps fight infection, and transport fat. Lymph nodes are important because they filter the fluid as it flows through the nodes. It traps bacteria and viruses, which are destroyed by lymphocytes, which are special white blood cells. Without the normal lymph drainage, fluid builds up and lymphedema can result then. Lymphedema, fancy definition, abnormal accumulation of protein-rich fluid found around the cells, which may cause chronic inflammation and reactive fibrosis of the affected tissues. Two types of lymphedema. One is primary lymphedema. People are born with something wrong with their lymphatic system. Secondary lymphedema can result from many different things, such as cancer, surgery, radiation, injury, scarring, trauma, chronic venous insufficiency, obesity, or an infection of the lymphatic system. Symptoms of lymphedema, feelings of heaviness, fullness, swelling of a body part, decreased flexibility, aching or discomfort, or thickening or hardening of the skin. Fortunately, there is treatment for lymphedema. We call it complete decongestive therapy. Our purpose is to decongest the body, so move the part where it's swollen back into the system. Manual lymphatic drainage is a type of light massage. It improves the activity of the lymphovascular system. In lymphedema, it reroutes the fluid. It goes from where it is swollen back into the centrally located lymph vessels, which drain then into the venous system. We use short stretch compression bandaging in therapy. That again helps increase the tissue pressure in the swollen extremities, helps move that fluid through. Same with the exercises, that's a big part of therapy. We wanted to do the exercises with, and then skin, nail care, and self-instruction is all, we want to educate our patients. We want to make sure that they know how to prevent infection, do everything they can for risk reduction practices too. What can they do so that swelling doesn't come back or worsen again? Sometimes people need to wear compression garments long-term to maintain that fluid loss also. In summary, unfortunately, prevention is not always feasible for lymphedema. Sometimes depending on the surgery or if they have to remove lymph nodes, it increases the risk to develop lymphedema. So then early treatment is recommended. The sooner someone can come in for therapy, the better. Before the skin makes the changes in the body, they can make more improvements. Unfortunately, there is no cure for lymphedema, but it can be very well managed with a good home, with completing therapy followed by a good home management program. And then patients don't have to be debilitated by lymphedema, but they can live a rewarding and successful life with lymphedema. Okay. Next we have Jan.
Can you guys hear okay in the back? All right. My name is Janet Martin. I am an occupational therapist as well, except that I just work with children. And from Wendy's description of OT, it probably says, what in the world do you do with kids? Because what will they do all day? They just play. But that's what I use in my therapy. I have been working about 40 years now. 21 of them have been here. Since I'm here, we have developed a pediatric clinic or group of therapists. It includes myself. Amy Tiafilo is also an OTR that works with children, and Dawn Kraus is a PT that works with children, and then we have a new speech therapist, Jen Moe, and she is also helping with our particular area. We service developmental delays of all kinds, because when a child has difficulties with any of the diagnoses that are here, they are going to show delays a lot of times in their development. So it includes genetic disorders, cancer, cerebral palsy, brachial plexus injury, autism spectrum disorders, sensory processing disorders, sensory integration disorders, visual motor problems, brain injuries, seizure disorders, and that's just part of it. We work out of the first floor here at the hospital. And so most of the time the children are seen as outpatients here. We do not usually see children on the inpatient side, although I have occasionally. As I said, we have a pediatric team, and we do service children from 0 to 18 years of age. We also have a contract with the Fond du Lac County Birth to 3 program. And as part of that particular program, we go into the homes. So if a child needs occupational therapy before the age of 3 due to a developmental disorder of some type, we will go into the home and work with the parents in understanding how they can help their child. We give them ideas as far as their development in all those gross motor, fine motor, speech, all of those different areas. We also recently developed the Agnesian Autism Behavior and Communication Center. We at first, in 2013, we started doing evaluations for autism out at Dowell & Associates. It involved myself and the speech therapist at that time, and we would meet along with Dr. Davenport and complete an autism evaluation that was a very well-rounded eval for autism, and we were able to direct parents to the services that are available to help their children. We saw children from 0 up to 18 in that particular clinic. It was really very good. Right now, Dr. Davenport left, and so we are now currently looking for another psychologist to help us with that particular evaluation. So one of my specialties is sensory integration treatment. It is specifically related to the child's development of their own sensory information. We are getting sensory information all day. You are getting information even as you just sit in the chair, how you sit upright, and there's sounds in here that you're mostly ignoring because maybe the air conditioner is running or something like that. Children who have sensory processing difficulties would have a hard time sitting here. They might be wiggling a lot, falling out of their chair. They would be distracted by the sound. They have a hard time attending to a teacher that's in the classroom, speaking to them, and they have a hard time sometimes with just their clothes. They're the kind of kid you get home and they strip their clothes. So these children need a lot of treatment, and that is my primary caseload. It's actually underneath a lot of the diagnoses that I see. I might see a child for Down syndrome, and they also have sensory processing difficulties, so I'm going to treat that along with the delays that they have. The sensory integration difficulties do affect largely autism spectrum disorder and as well as ADHD, and there, like I said, there's other diagnoses, but if a child has autism, which that is a good chunk of my caseload, they, 95% of the time, they have severe issues with sensory integration. Although it can stand by itself as well. A child can just have that sensory issue. It's oversensitivity, avoiding the sensory input, or sometimes they are seeking it. It's like a low registration, so they are bouncing around the room trying to figure out what is really relevant to them. Often they have poor motor coordination. They have the inability to regulate their behavior and responses to that sensory input, so that's what I am helping them with. They have an inability, as I said, to often attend for learning due to that overload in the sensory seeking. When you watch me work, it looks like I'm just playing with children, because that's what kids do, they just play. But I incorporate into that play the therapeutic needs that they have. I treat those therapeutic needs with the use of play so that they will respond to me, because I can't sit down and, you know, have them do exercises. They just want to play. So that's what I incorporated into. Oops.
Okay. Physical therapy, I'm going to talk just briefly physical therapists. Most of you in here know what physical therapy is. When I try to describe it, my wife teaches in a program too for physical therapy assistants. Basically, we're experts on motion and movement. And so if you have a problem with either of those two, that's what we treat and how and why we're here. There's a lot of details behind that, what leads up to it, what causes it, and I'll talk about that a little bit, and some of us will talk about those in our own instances. I mean, a lot of the therapy has been shown, there's a lot of studies coming out. I put avoid surgery prescription drugs. I mean, there's a lot of equivocal studies that show if you have physical therapy for whether it's knee arthritis, lumbar, you know, like a herniated disc, cervical spine herniated disc, rotator cuff stuff. Basically, if you take a period of time of physical therapy without the prescription of the surgeries, and you have physical therapy, then you look 6 weeks out or you look 12 weeks out, you have equivocal outcomes. And so the tough part for a lot of patients is getting through that acute flare-up phase. And there's some things that need it. Some things need surgery, some things need medicines. They do have a very important role. But just for physical therapy perspective, there's a lot of things that if you can teach the cause and get at the root of what was happening, a lot of our other treatments are post-injury, we're doing this. We never get at what caused that. And so you have a herniated disc in your back, and then you have a level, either a laminectomy or you have something fused. If you don't get back at that person and look at the way they move and what they do for their job and get at that, they're just going to keep on doing it again and hurt all the way up the level. So the earlier you can start those things, the better. And that's where it gets into the movement, motion, and what we do. The other thing that I think is important for us is it happens in all professions, but our visits are usually between an hour and 45 minutes of one-on-one time, hands-on. You know, there's a lot of clinics in the country that don't design it that way. We're with you, one-on-one, the whole time with a licensed professional. So you're doing and working, and you're really having that person taking their goals and trying to work with them to get to where they need to be, and you can adjust that as you need to. Schooling-wise, every physical therapy program in the country right now is doctorate trained as they come out, so everyone has a DPT. We have many of our therapists that have went back to school, whether they had a bachelor's or master's, and decided that was right for them to go back and get what's called a transitional doctorate, so a lot of hours have been put in by our staff. We still have a ton of therapists that are masters or bachelors, and I would see them in a snap. I mean, they're experts yet, but just to get an idea of where the profession's going and what's coming out, it's all doctorate right now. There's still in any given clinic a fair amount of masters and bachelor trained physical therapists. I have my doctorate and went back and got it after I had my master's. My wife, I went to school with her. She decided not to at this time, so she's treating and doing a great job. But just an example of what's right for each person and what they do. What we treat, there's probably too many diagnoses to really talk about. If you have a movement problem, whether it's from a neurological problem, orthopedic condition, some people just have bad mechanics of what they've done. That's what we treat. We're experts in looking at what that person's doing. I'm a pencil pusher now. I don't treat. I treated for about 10 years. I still, every time I see someone walk or do something, I still analyze what they're doing. I can look at someone and be like, oh, that person's weak here, or that person does this wrong, or that person does this wrong. So it's probably similar to a psychologist that you try to shut it down, but when I watch someone move or do something, or my wife and I, she's a therapist, we'll look at each other and we'll both think the same thing, because we're a little bit of dorks. So that's the way we look at the world. You can't turn it off from what we do, but that's what we like. Like I said, orthopedic-wise, we see about 50% of our business in the outpatient clinics are back and neck pain. So we see a lot of back and neck pain. We do it all the time. But then there's a lot of shoulder, hip, and knee. We'll talk about a little bit with sports medicine. And just back to, there's, inpatient, you have people that have pneumonia, you have people that have strokes, you have people that have head injuries. There's reasons why people move different ways. I've seen athletes that have had partial spinal cord injuries where they can't feel their legs, but they have the strength, and so we're working with them. They don't know how to move, they don't know how to gauge the strength of their movement, so we do all that. We'll talk about some of the specialty programs. Some that we won't hit today is we have experts like in TMJ disorders, we have incontinence experts, we have some people that treat almost all spine, and we have some specialists that do almost all foot and ankle things, and a couple of the other stuff we'll talk about next. Here's one of them. I keep leaving my sheet up there.
My name is Inga Meixel. I'm a physical therapist at Ribbon Medical Center. I'm going to be talking to you today about vestibular disorders. I also teach in a transitional doctorate program for the College of St. Scholastica, so we get our fingers and toes in all sorts of activities as therapists. So for a lot of people, when I say vestibular disorders, they look at me like they have no idea what I'm talking about. So the quick and dirty of it is, it's dizziness, okay? And then when I say that we treat dizziness in therapy, people are like, how do you do that? So just to give you a rundown, so your vestibular system is a sensory system that provides information to your central nervous system regarding your sense of balance and spatial orientation for the purpose of coordinating movement and balance. That's a lot. Specifically, it's rotational movements and linear acceleration. So what does that mean? Your vestibular system just tells you where you are in space when you're moving around. So there are disorders for people where they can't figure out where they are in space when they're moving around. Well, that really sucks, doesn't it? One of the symptoms that we sometimes see with people is oscillopsia. It's up there on the board. That's when people have both sides of their vestibular system, so both inner ear sides don't work. So even when they're standing still in space, everything is moving. So if you can imagine, that would be really horrible to have. So I just put this slide up here because I'm not going to go through the anatomy of the vestibular system with you, but just to let you know, this is a very complex system in your inner ear. It fits on a surface size less than a dime inside of your body, and it is extremely important, as I just noted before, in terms of like moving around in the world. This is what keeps you upright. So there's a big sac with 3 canals that come off of it. The whole thing is filled with hairs and little crystals and fluid, and basically its job is to tell you, when I turn my head to the left, don't fall to the left, okay? So it's a feedback loop that keeps you upright. When I turn my head to the left, my body responds to not fall to the left, and same with to the right and up and down. So in terms of the terminology that we use dizziness as kind of a general terminology, but what a lot of people will come into me and say, well, my doctor says I have vertigo, okay? In order to have vertigo, you have to have movement of the environment around you, and true vertigo requires rotation. So if you have somebody that tells you, I have vertigo, and you say, oh, does the room spin? And they say no, then they don't have vertigo, they have dizziness, okay? And then we also treat anything associated with unsteadiness or just inability to move around well in space. In order to diagnose this in physical therapy, because a lot of times I have patients that just come in from their general practitioners with just the diagnosis of dizziness, we do a lot of things. We look at what they call an oculomotor exam. That's when the doctor makes you look at your pen and follow my pen and move this around, and we want to see how your eyes move in space. Just general stance and gait, range of motion of your neck, balance. So we go through quite a comprehensive examination to determine what is actually causing the dizziness or vertigo. There's a lot of diagnoses that we come up with for vestibular problems. The most common thing that we see in therapy is something called benign paroxysmal positional vertigo, or BPPV, and there probably is somebody in this room that's had it before. It's actually quite common. But we treat a bunch of different things. You'll see on the list here post-concussion syndrome. Concussions being a big thing now. We actually can treat people who have long-standing post-concussion syndrome. And then vestibular migraines is the other thing that's starting to come forward with that, as people who get migraines sometimes also have associated dizziness. So those are people that we should be also seeing in therapy. And then post-stroke as well. If you have a cerebellar stroke, you would have difficulties with spatial orientation. Treatment and physical therapy. So to treat BPPV, the most common, we do what's called cannula 3 positioning techniques. And you can kind of think about it like this, because I'm old school. I don't look it, but I've been a therapist for 11 years, so I grew up where there was no computers or anything, so we had to do different things to amuse ourselves. And back in the day, we had these little games that were like a little ball that you had to move around on the board to get from one place to another, okay? So a cannula 3 positioning technique is where we have to move your head around to get those little crystals in that inner ear from the spot that they're in that they're not supposed to be to the spot that they're supposed to be. So you'll hear people say like, oh, I went to physical therapy and they threw me around the table and then my dizziness went away. We don't actually throw people around the table, but it is a series of movements that we do to get things back into place. And then we also do exercises to help them adapt and habituate in the environment. If they have a decreased function of their vestibular system, or potentially if they had a cerebellar stroke, we work a lot on walking and just general balance and that kind of thing. Wait, I went the wrong direction. Okay.
It's me again.
Oh, sorry. So I just wanted to let everyone know that we treat vestibular dysfunctions in all of our clinics.
Yeah, I forgot to say earlier, you guys have a sheet in front of you. And so that sheet shows a lot of the locations. We have a lot of the stuff that we have, we try to have it spread out as much as we can for ease of patients. So you can kind of see underneath the various locations of the type of specialty. Some things, we have 4 speech therapists. They're already treating at the 3 hospitals. We can't have them at every clinic all the time. You have limits to resources. But we try to have, we have someone for vestibular at all locations. We have someone that does like incontinence stuff at most locations. Pediatrics is more of a specialty thing, so we don't have that everywhere. So you can see that kind of in the sheet as we talk about some of the stuff. We have someone like, oh, is it here? It should be answered on there, otherwise we can talk about it in a little bit. I'm pinch hitting, someone's coming at noon too, but prior to being a pencil pusher, like I said, I did sports medicine for a little over 10 years. I was an athlete trainer out the schools for 5 years, as well as dual sports medicine clinic as a physical therapist. So I want to speak just briefly about our sports medicine program. I mean, most of you know what it is. It's mostly adolescents all the way up through our weekend warriors and our older recreational athletes. Orthopedics and foot and ankle doctors are our primary our referral sources. We have the 6 orthos out on Camelot Drive. We have 2 in Waupun, 1 in Ripon. We have a really good relationship with them. What's great on Camelot Drive now is literally here's our department, and then there's Dr. Rutger's office, here's Dr. Kemp's office. You can walk right over. So they're coming back and forth all the time. And then also the foot and ankle docs are podiatry, family foot clinic that was family foot clinic. They're right there too. We have a shared reception scheduling model. So I think it's good for patients. A lot of collaboration and conversation going back and forth. Things we see, I'm not going to go through every single one. ACL, the stuff that's important, or any knee injury, our goal is, through those team of people, our athlete trainer, our physical therapist, and then the athlete and the coaches, is trying to progress those person back in a safe manner to what they want to do. And so there's a lot of functional return and slowly progressing to make sure that we're safe to the surgery. We do things like, there's a machine where we can test the strength on one side versus the other comparatively at different speeds and resistances. We do a lot of what's called, when we say functional testing, we're going to look at their ability to how they squat. So we may go 2-foot squat. We may go good leg how they squat. What does it look like on this leg? Do they start falling in? Can they control it? We'll do some deceleration things. So you're moving, and can they at a slower speed, can they go from moving to stopping safely? Can you speed it up? So that's kind of things that we do to progress them back. And then we have the experts, and Corey will talk a little bit about that, all the schools that do that final leg. The difference between me and you, if I tore my ACL right now, hopefully I get back to that 80%, and I'd be pretty functional, and I could hit a golf ball, and I could play around with my kids. But the difference of what we have to do in sports medicine is 80% is going to get them re-injured or off the team, or not back to the thing they want to do. And so the sports medicine professionals and what we do is really trying to get them that last leg, because a lot of us you still need therapy, I think, to a lot of extent, but to get that last leg, you really need some specialized progression in what you're doing. Rotator cuff stuff, we see a lot. We do return to golf, so we have a lot of golfers. Well, I can't hit a golf ball. Well, yeah, you can't, but we have programs where we progress them from like little chips or putts to middle irons to distance irons. And there's a lot of progressing, throwing rotator cuffs. How many throws can you do? Little league pitchers with elbow problems, talking to them about mechanics, talking about how much you can throw, talking about pitch counts, all those things. Those are things that we work on and doing. We see a lot of kind of nasty stuff, fractures, dislocations, things like that. I remember the first dislocation I ever saw as a kid dislocated his kneecap, and I was the first one on the scene, and I was doing, and he had been a chronic dislocator, but you just look, the first time seeing that and just having this kneecap sitting over on the outside of your leg, it's pretty, it's interesting to see that way. His went in, and he made a sweet and then a big swear word. He was really happy that his kneecap popped back in, and we did it, so it's pretty funny when you see some of them after the fact. We do a lot of running stuff. We have like video analysis where we tape people, we can slow-mo it, we can look at what they're doing, we look at compensatory patterns of their feet, their hips, their body. Joel out at Camelot Drive does a lot of stride length stuff. A lot of people take too long of a stride when they run. The longer the stride, the more the impact force. There's a lot of studies that say if you can shorten your stride length up a little bit and increase your cadence, you can increase your speed of running without having problems. So if that makes sense. I run longer, bigger strides, I have more kind of hitting. It's really hard on your knees, so he does a lot of work with people that we shorten that stride length up, and you can get people that had a lot of chronic knee pain with running, and they can get rid of that. Like video analysis, sometimes you can see one person really torques, they're kind of rolling in, and I'm exaggerating it, but hey, what's going on here? We can look at them. They have weakness in their hip, so they don't have that strength to keep things lined up. So we look and work on people like that all the time. The other thing that we do is we well coordinate the athletic trainers. We couldn't do what we do here without them. And then a lot of the people are trying to get back to, the zone, the wellness centers at Ripon, our tag center in Mayville, TNT Fitness, all those stuff. So we're trying to help progress and bridge that gap to get them back to do those things. And that's what we feel comfortable with. Most of the people, there's numerous people in this community that we have connections with. And so it's nice to have that continuum of care, get people back to what they want to do, and that's what we get and find rewarding.
My name is Maria Dricken. I am one of the physical therapists that specialize in treating complex neuromuscular pain conditions. I've been with Agnesian HealthCare as a physical therapist since 1996 and have specialized into this area and helped develop what we call the pain team in physical therapy. So the pain team of physical therapists is just a group of therapists that specialize in treating people that have chronic pain. Kind of in contrast to what Zach brought up, treating kind of acute pain, figuring out things, figuring out what the problem is. The people that we see really don't have an explanation to explain their pain. They may have gone through multiple providers for treatment, multiple tests, MRIs, x-rays, and nothing's there, but yet they still have the pain. So then what? And those are the individuals that we see. The physicians that refer to us are mainly physicians from the Center for Pain Care and Physiatry, although we receive referrals from family practice physicians, internal medicine, physicians from outside of our organization also. Since we're dealing with the complex pain condition, we have a, oops, I have to do this, don't I? multidisciplinary approach to care. A person that experiences chronic pain, if they go to their physician, receive pain medication, likely that's not going to work. It has multi-facets of care that need to be addressed. So we work with a psychologist that specializes in treating pain more from a cognitive perspective. We work with physiatry, Center of Pain Care, psychology, nurse practitioners, and physical therapists. We meet with physicians from the Center for Pain Care on a weekly basis, and then that whole group that I just listed, we meet a few times a year, and we discuss the patient's plan of care and how we're going to approach that to get the best outcome possible. It's more of a holistic approach. From a physical therapy standpoint, of course, we treat pain using non-pharmacological pain management strategies, which is very much dependent upon that individual, what that actually is going to be. Probably one of the primary things we do is anything we do is backed by research. So when we try to help an individual understand what's going on with them and try to help explain that pain, there's a lot of research behind that. And the research in the area of chronic pain over the last 10 years has just exploded, which opens up a lot of new ideas to help manage that condition.
Just to plug while Neil's getting his stuff together. The chronic pain program we tracked for a long time, even when she says the pain scores, they've had this forever. These people are getting a lot of functional return. That's a lot of their goal. But even the pain relief stuff, they're marking their pain half of what it was coming in. A lot of these people had it for a long period of time with that multidisciplinary approach. Pretty cool.
My name is Neil Gertig. I'm a physical therapist. I've been here since 2001. And one of the specialties I do is physical therapy in the ICU. And most people are like, "What? That's crazy. Those people are really sick. What are you doing down there?" So hopefully this can help understand that a little bit and help my day when I go down there too. I don't have people giving me nasty looks. So who do we see down in the intensive care unit? Dr. Lilly is a huge proponent for us. We see literally all of his cardiac and thoracic surgeries day one, post-op. Getting people just up to the chair, getting them moving, walking if they're able to that first day after surgery, and it's been great. We also see people on ventilators, people who are sedated, they can't move, so we move them for them, keep their strength up, keep their mobility in their joints and their muscles, keep them going. Trauma, post-surgical, sepsis, all kinds, really anyone in the ICU we see. Dr. Batar helps us with that a lot. It's not uncommon when he's on for the week for me to be seeing anywhere from 5 to 8 to 10 people down in intensive care. The intensive care is a very dynamic environment. Changes occur not only daily, but sometimes hourly. I'll go down at 8 o'clock and my patient that I'm about to see will still be on the ventilator. By 9:30, they're up in the chair off of the ventilator. So things can happen very quickly down there. And my plan of care, my treatment plans for that day, they can change, sometimes on a whim, which is exciting and it's fun for me down there. We are definitely part of the interdisciplinary team, working with the doctors, the nurses, respiratory therapy, helping us get things going and selected, and then also with the care management team. So real quickly, just some of the treatments that we do: range of motion, strengthening, transfer training. So getting someone to the edge of the bed, for some people that's a big deal, just being able to sit up at the side of the bed for 5-10 minutes. We have tilt tables, so it's a table that you slide the person over laying down, and we're able to tilt them up into standing, varying degrees of standing. I just had a patient, he was 6'3", 450 pounds. He spent a week on a ventilator. He was a noodle. But we were able to stand him, get him some weight bearing and some strength through his legs by using that tilt table, or otherwise we wouldn't be able to stand him. And a week after he left ICU, he was back at home walking independently again. So it really helps us keep things going. walking and balance training are two other things we do. So what are the goals? The primary goals, get them upright, get them moving. The sooner we can do that, the sooner we can stem some of the effects of immobility, like pneumonia, muscle weakness, contractures, all that type of things. Some of the benefits of early mobility, more and more studies are coming out that show that with physical therapy starting early, mobility starting earlier, we can decrease how sick people get, some of the morbidity. We can decrease their ICU length of stay, decrease their overall hospital length of stay, and thereby decreasing some of their costs of being in the hospital. Always a benefit. I assist with the healthcare team, determining what's the best way to get someone up, how often should they be getting up, what's the best way to move them around, and giving them activities to do to help throughout their day as well. And another big part that I do is help determine the next step for rehab. How many people need to go out to the medical floor, or can we avoid that, go right up to the transitional care unit, right to our acute inpatient rehab unit? Where are they at? When can we help them be ready for those next periods? Next step. And then just for a quick shameless plug for our acute inpatient rehab program. It's a phenomenal program. It's an intensive therapy program that we try to hit all facets of the patient. So we've got the patient, the family, the rehab nurse, physical therapy, occupational and speech therapist. We have a psychologist on the unit, social work, and also a chaplain to really try to hit all angles of that patient while they're undergoing rehab. It's an intensive program. They'll have at least